Hello, welcome back to my channel. My name is Gia. I'm your friendly family nurse practitioner, and today I am very excited to talk to you about acute low back pain. And so this is also a common complaint in primary care, and I hope that by the end of this video, you'll feel a little bit better taking care of a patient that come to you for this complaint. All right, so let's begin. So acute low back pain is considered as low back pain less than 12 weeks. Okay, and so as with any other complaint, I want to make sure that we will consider the red flags, or a serious condition that could be the cause of your patient's low back pain. So you want to make sure to assess for any recent trauma, any fever or IV drug use, because you're going to consider infection or osteomyelitis, urinary retention, fecal incontinence, saddle anesthesia. These are signs or symptoms of Quad-Aquena syndrome, weight loss, and history of malignancy. Okay? And so for presence of red flags, and if you notice that patient has one or two of those red flags, you want to evaluate for malignancy, any history of cancer, infection, fracture and osteoporosis, rheumatoid disease, and Quad-Aquena syndrome. So your workup for this is going to be CBC with diff, your ESR, alphos, and urinalysis. Okay, and because sometimes you could have a urinary tract infection, and that can refer to your back. Okay, so you want to consider X-ray of point of maximal tenderness. So when you do your physical examination, you want to make sure that you press onto those lumbar spine, and don't be afraid to push hard, because you want to make sure to evaluate in the area. You want to evaluate the area around your SI, your SI joint. You want to make sure to press on those areas too. And you can consider CT or MRI if there's radiculopathy. You will consult neurosurgery if you notice Quad-Aquena syndrome, and this is an emergency. Okay, you want to make sure to refer your patient to higher level of care. And then if you're suspecting infectious as an etiology of low back pain, you will refer the patient to ID. But if you're not able to refer them immediately, you can transfer the patient to emergency. Okay, so your workup's gonna start. If there's no red flags, you already rule out the red flags. There's no fever. For a patient that is complaining of pain, worse with extension, like standing, walking up and down the stairs. And sometimes patient may also come to you like, Gia, when I go to the grocery store, I'm walking and then I have pain, so I have to lean down on the cart, and that relieves the pain a little bit. So that's a sign of spinal stenosis, or that's a symptom of spinal stenosis. So order an MRI to rule that out. If the pain is unilateral, one side, patient will complain of pain, numbness down to one extremity without signs of bladder malfunction. So the bladder malfunction here is not urinary incontinence, but more so urinary retention. So your diagnosis for this patient with unilateral pain and numbness down one extremity is going to be radiculopathy. And you can start them with conservative treatment, physical therapy, NSAIDs, oral NSAIDs, or topical NSAIDs, Tylenol. Okay? For all others, you're going to diagnose, your main diagnosis probably is musculoskeletal low back pain, from lumbar strain, muscle strain in the area. So conservative treatment for 4 to 6 weeks Return to work in 1 to 2 days. And sometimes patient will present to you with severe pain. But as long as you did your due diligence in making sure to rule out the red flags or serious causes of like low acute back pain symptoms, you'll be reassured that this is just muscle strain. Sometimes also a disc herniation can also present as an acute low back pain. No bed rest or narcotics. But I think I shared this to you before. If a patient really has severe pain and you feel it and they're not like just saying it so that you can give them narcotics, I sometimes consider it special case, no more than 7 days of supply, and I make it a point that I'll tell them I'm not going to refill this because this is not good for long-term treatment of pain. It's only going to be for 4 days. And after that, we're going to consider something else. So you have to make sure you make it very clear at the very beginning. So NSAIDs plus minus muscle relaxants, and I always give this. Muscle relaxants is good for relaxing the muscles and more effective for helping them sleep at night rather than pain control. But I have patients that says that muscle relaxants help with their pain also. Stretching exercises, physical therapy, osteopathic manipulation. All right, so for persistent symptoms, after we've already done physical therapy, 12 weeks, 6 weeks, and they still come back to you for persistent pain. So check ESR, LDH, ALK Phos, X-ray of lumbar spine. So if the labs are normal, you can reassure that this is not malignancy, this is not any serious condition that's causing the pain. Refer them to physiatrist or physical medicine and rehab, and or MRI only if the patient is willing to consider more aggressive treatment. Okay, like surgery. If labs are abnormal, you want to evaluate for bone abnormality, including osteomyelitis, cancer, METs, or fracture. You can consider MRI or bone scan. Okay? Alright, so I hope this video is helpful to you guys. Remember, this is just a review, a touch up on the things that you've already learned, and I hope this is helpful. Remember, I'm your friend and your mentor. If you have any conditions that you want me to cover, let me know. Leave it in the comment section. And this is also helpful for me because it helps me to retain knowledge and to relearn the things that I need to learn to practice. So see you next time.